We'll go ahead and get started. Today's learning objectives include that we will be reviewing let me get to those. Okay, that will define the roles of clinicians and patients in chronic care management. I want to describe the chronic care perspectives and how they influence our approach to chronic disease management. We'll review the 4M's framework as it relates to chronic disease management, and then we'll identify shared decision-making techniques to promote self-management in chronic disease. We'll then review evidence-based resources to support chronic care management. So chronic disease is obviously common for older adults, age 65 plus. At least 80% of older adults have at least one chronic condition, but 68% have 2 or more chronic conditions. And these are some of the most common, including hypertension, high cholesterol, arthritis, and some of the others here that you can see. These are some of my favorite quotes that I like to discuss. So before you heal someone, ask him if he's willing to give up the thing that made him sick, and this is Hippocrates. While I have an illness, I am not my illness, it is merely a part of me. And then never let the things you cannot do prevent you from doing the things you can. So very important approach, as we talk to our patients with chronic disease. So some patient perspectives include really that they don't have overt symptoms that impact their daily lives, and they deny or minimize the impact of chronic disease on their lives. They want to be well, and they often do feel that way when they're not experiencing symptoms. And they don't want to take medications. Most patients are resistant to taking medication if that's a part of their treatment plan. The diagnosis of a disease often has an important and negative connotation, so this impacts their mental health and emotional well-being. Chronic disease from a provider perspective can include that we do have limited time with patients. Educating patients about chronic disease is complex and it can be a lengthy process. Providers do vary in their skills and interest in educating patients and explaining and understanding where a given patient is in their trajectory and their understanding of their own diagnosis. Many providers are fatigued, and especially with the pandemic, we're burnt out, and sometimes the feeling is that it's just not worth it. And this can lead to that self-fulfilling prophecy of dissatisfaction between patient and provider, and even non-adherence with the treatment plan. So I like to really sit down with my patients and define roles. And I find that this often helps me understand what my role is and the patient understand what my role is and understand what their role is, helping them to understand that I'm not the one in charge of their health, that really they're the one paddling the boat. So the purpose for this is this helps prevent me from burning out, but also helps the patient and caregiver understanding their responsibility in their own care. So I explain the analogy with the river and the boat. The river really is their health process, their own life and how their health is. Sometimes it's smooth sailing, especially when we're young and healthy, the river is nice and smooth. When we get to turbulence, that's the process of the disease, right? We might hit some rocks and turbulence in the road, and that's the disease process. The boat really is the health behaviors in the treatment plan, and how well they take care of the boat helps them navigate the river. And so their responsibility is to take care of that boat and help determine what kind of boat they get into. The rower is the patient. So I'm not the rower. I'm not going to get in the boat and row the boat with them. They're the rower, so they're in charge of navigating the river themselves. And the oars really are the adherents. So how well they paddle that boat is going to determine, and where they paddle the boat is going to determine how they adhere to the plan. If they stop rowing, they're not gonna get down the river. And so you might ask in this picture, well, where's the provider? Well, the provider's not in the boat. We're not in the picture. We're on the sidelines. We're the coach with the bullhorn going, good job, you're doing great. Oh, okay, there's some turbulence. Here's what's gonna happen upstream, or downstream. You're gonna hit some turbulence. There's a rapid ahead. So we're the ones really coaching them and cheering from the sidelines. But we're not gonna ever get in the boat. We're not gonna help them row. We're just gonna coach. And so that's kind of the way I like to describe this to patients, so that I understand and they understand what I'm doing. So health promotion strategies. So when we talk about chronic disease, rather than a reactionary approach, I like to talk about health promotion, even within the face of chronic disease. So we often go, okay, there's a symptom, there's a disease condition, now we react and we treat from the reactionary perspective rather than a health promotion approach. And so I really try to attempt my patients to say, with with diabetes, how are we promoting your health? With hypertension, how are we going to promote your health? And let's think about it that way so that we're not rescuing you with a life raft when you're in the midst of an exacerbation, but we're actually helping you when you're feeling really well and doing well to make sure that as we get down that river, that you're well prepared to face those challenges. So levels of prevention, let's talk a little bit about that. And primordial levels of prevention is really where we can help affect social determinants of health and access. And this is where we can get involved in leadership and how are we affecting change in those social determinants of health? How are we improving access for our patients? With primary prevention, of course, we need to constantly think of how are we minimizing their risks? What diseases do they not have yet? What can we still help prevent? And how can we promote those healthy behaviors that they're still engaging in? And how can we increase those healthy behaviors? With secondary prevention, we want to continue to screen those at-risk individuals. Early detection so that before they're symptomatic, we're catching those diseases and catching them early. And then with tertiary prevention, of course, we're treating established disease. We want to minimize complications at the end, reduce end organ damage, but we have to remind patients that this is what we're trying to do with treatment. Even though they're not feeling symptomatic now, we want to prevent them from being symptomatic later, and that's why our treatment plan really is, that's what the goal is of our treatment plan. We tend to think of treating older adults as here. This is where we kind of focus, but I want to challenge you to think of treating older adults also in this realm of continuing to prevent, because we can start this earlier. We can start it with our adult patients. We can also start it with our young adult patients. Chronic diseases are preventable, and I still like to speak this language with older adults in that 70% of cardiovascular disease and type 2 diabetes and 40% of cancer are preventable with 4 behaviors that they can do themselves, which we know are exercise, diet, not smoking, and then avoiding alcohol, heavy alcohol consumption. Health promotion for older adults consists of continuing to screen. So utilizing age-appropriate resources and doing screening, but considering prognosis. So making sure that we're not over-screening, and then utilizing tools like the American Geriatrics Society, as well as choosing wisely for older adults. So this is a great document that you can click on this link and use. And this is from choosingwisely.org, but this one specifically is for older adults. Using your anticipatory guidelines to say, hey, here's what you're dealing with right now, but here's what you could face downstream, okay? Here's what could happen later. And even though you feel great now, here's what we want to prevent from happening. And then utilizing your wellness visits, making sure that we have a mechanism in place to get those patients in every year. At UCI, we do our HAPS visits for seniors, which is our health assessment program, and 2-part visit where they really come in and we're doing some screening with, looking at their functional status, assessing their cognitive status, depression screening, and then age-appropriate physical exam, maybe collecting some labs. We come back in for a second part, summarize our findings and come up with our treatment plan and discuss kind of goals for care. And then we want to look at every chronic disease from the framework of the 4 M's. This is really important to consider because this is looking at the age-friendly approach to providing care. And that includes, of course, mind, mobility, medications, but specifically to what matters most. And we'll spend a lot of time today talking about our approach to what matters most. But I'll touch on the other 3 just briefly. When we look at mind, we know that dementia is progressive, but if we manage chronic diseases well, we can minimize the risk for dementia. We know that there are specific chronic diseases that can lead to increasing the risk of dementia. And then we also know that depression is more common with chronic diseases, especially in people who have 2 or more. So we need to make sure that we're formally screening for depression. And that's because depression is often underdiagnosed or misdiagnosed. We can do this by using the PHQ-2. There's a link for that here. If patients score 3 or higher, we really need to do more digging. We need to, make sure that we're screening them by doing a longer screening like the PHQ-9 and addressing the depression, not letting that go or minimizing that depression. With mentation, assessing cognitive function really should be happening informally at every visit, but formally at the annual visit, and then as needed as cognitive changes or status changes are happening. So if the family's bringing up a concern, if you're noticing the patient's acting differently or is acting confused, has had a mental status change during a hospital visit, we need to do another formal assessment at those touch points. And then delirium is obviously treatable, but it's acute onset. So one thing that we'll see is often during transitions of care, when patients are moving from inpatient to a skilled nursing or from rehab back to outpatient, points of delirium these are risk points where delirium may happen, whether it's because of an acute infection or an acute exacerbation of a chronic disease or metabolic imbalance, dehydration. These acute delirium will happen, and maybe the patient gets labeled as dementia. So that label of dementia or diagnosis gets put on the chart, and then we'll follow them through certain admissions. And so all of a sudden, we've got, wait a second, now they have dementia, but that was never formally diagnosed. It was they had a period of delirium, but they got misdiagnosed as dementia. So knowing the difference between these three, but also educating our partners in skilled nursing facilities, in inpatient facilities, and those in other care points in home health to help understand the differences between the three so that these mislabeling doesn't occur as well. Mobility is important. We need to understand that falls obviously increase the risk for morbidity and mortality, but we should be doing formal fall risk assessments. This should be happening at least once a year, but if they're having frequency of falls, so if they have 2 or more falls per year, difficulties with gait or balance, or if they've sought medical attention or have had an ER visit because of a fall within the past year, then there should be a multifactorial fall assessment. That's more comprehensive. Let's talk about what that consists of. In the history, you would be doing what are the circumstances surrounding each of those falls that have happened, a full medication review, including recent changes, any dose changes, any stop or starts. Are they on the Beers criteria? And then chronic conditions that might contribute to a fall or might lead to a fall, a formal cognitive assessment, and then a functional assessment, including the CATs, we'll talk about that, or fall risks. The physical exam would include obviously orthostatic vitals, a general appearance, a skin assessment to see if there's evidence of any other injuries or other accidents, a cardiovascular assessment, possibly a GI or respiratory if they've got some anemia or a chronic condition that might be causing shortness of breath or desaturation, a musculoskeletal with gait and a timed up and go test, we'll talk about that in a bit, and then a neurological exam. So this would be a more comprehensive and is warranted if they meet those conditions that we talked about previously. The timed up and go test, this is a PDF version. If it's not built into your EMR, this is a really user-friendly version. The link is here. And then the CATS ADL's assessment tool, this is one I like to use particularly when I have patients who have either had repeated falls, if they're unsteady, if they've had family members who are concerned, if I'm concerned about them being alone, if we're having that conversation of they've had falls, they're unsteady, should they be alone, should they not? I pull out this tool because it's a great visual for us to go through and say, okay, what are they doing independently? What are they not doing independently? What do they need help with? And when you're looking at the scoring, you're going, okay, they're actually not totally independent. It may be time to look at least bringing a caregiver in. If for anything, just at least to do some of the ADLs, maybe they've fallen when they've bathed. It's every time they've fallen, it's when they're trying to get in and out of the shower or bathing. This will help let you to know, okay, we need a caregiver in for those times, or we need some assist devices in the home to, modify the home better. So this tool really kind of helps you sit down and have that conversation with the family and the patient. Medication. The multi-comorbidities and optimal prescribing strategies include looking at symptomatology, and when patients come in with complaints saying, can we address this with something other than a prescription? Can we use other modalities, especially when it comes to things like pain or nausea? Can we address this, without using medications? Can we identify interventions that target multiple conditions? If we're talking about diabetes and heart failure, right? If we're talking about hypertension and diabetes and renal, right? Can we prescribe medications that cover multiple conditions at once so that we get the most bang for our buck? Once we decide those things, Is it on the Beers criteria, avoiding things that are on that list? And then we look at the American Geriatrics Society guidelines for multiple chronic conditions, and we have to ask, identify those patients' health priorities and their own trajectory. And we stop, start, and continue based on their health priorities. What is their prognosis? What are their health goals? What do they want to do? What do they want to do short term and long term? And does this prescription fit within those goals? Are we gaining more than we're losing? Does the side effect profile, is it more harmful? Is the burden of the side effect profile, outweigh the benefit? So really weighing the costs and the benefits. And then aligning those decisions amongst the patient, caregiver, and the providers. Deprescribing, again, the planned process of really reducing and stopping medications that may no longer be a benefit. This is a website that you can look at. There are deprescribing algorithms listed, and we'll show you one, but really reducing medication burden and increasing quality of life. And this needs to be done really a good review at every wellness visit, but also at chronic care visits when you're looking at the plan for this particular condition. When we're looking at episodic visits and there's a symptom, looking at that symptom, could it be caused by a medication they've recently been started on or increased? Has there been a dose change? Have they stopped something, or did they start something again that maybe had been discontinued before and they forgot about it being discontinued and they started it again? After an incident or injury, so they've had a recent hospitalization for a fall. Did they, has it been something that we recently prescribed that could be contributing? An example of this is a PPI. So we've got a lot of seniors who are on PPIs or they're left on them for years. We need to consider, why are they still on it? And so this is kind of an example. Is the indication is unknown, then we consider decreasing to a lower dose or stop and then use on demand. Or is it for a known condition? Yes, continue the PPI or consult the GI doc, or do they have a condition that we knew about, they did a full treatment, and then we go ahead and trial a stop period and see if the symptoms return. So this kind of just guides you, based on the condition or what was known, or if there was no known condition, go ahead and stop, recommendations for stopping it or reducing it, and then tapering down. Other priorities of surrounding medications really are during transitions of care, and that's because we know that errors in transitions can lead to not only increased readmission rates, but increased mortality and morbidity, adverse events, delays in treatment and support, additional primary care and ED visits, additional or duplicated tests, we see this a lot, lost to follow-up, emotional, physical, and mental pain and suffering, patient and provider dissatisfaction with care coordination. So these are common complaints that have been documented, well documented, and we're in a unique position as primary care providers really to drive that, to drive the ship and be a part of the solution and coordinate. And so we have to identify the ways in which we do that. And then these are some examples, specific examples. So an 80-year-old retired school teacher visited the ED 4 times in a month for exacerbations to mild heart failure condition, 2 of those times requiring hospitalization. When provided with discharge instructions, she can repeat them back, however she doesn't follow through after returning home because she hasn't yet been diagnosed with dementia. And then after falling at home, a 78-year-old woman received 3 new prescriptions for her primary care because during the exam, her blood pressure was 164/90. The doctor instructed her to start the new medication for hypertension the same day, stop her current blood pressure medication the following day. 2 days later, the home care nurse came to see her. The patient had a headache and dizziness, and the nurse noted that her blood pressure was 190/96. When the nurse asked her what medication she was taking, she said she'd stopped her old blood pressure medication like the doctor told me to. When the nurse asked about her new medication for hypertension, the patient became upset and said she didn't have them. When the nurse asked her why, the woman said, "Because we don't have the money to get them, that's why." The woman was on Medicare, but they did not have enough money for the copay amounts for the new medications. So these are some examples of when things get, missed, or when there are issues with transitions in care. What matters most to you? So this is the fourth M, and the aim really here is to align care and decisions with older adults' healthcare outcome priorities and goals. And this promotes ongoing communication and relationship building with older adults, caregivers, and the providers. And the operationalization really happens over time. So this doesn't happen overnight. It's a long process. Happens over multiple touch points. So opportunities include at wellness visits, anytime there's a status change, chronic disease management appointments, life stage changes, inpatient visits, and then a variety of settings. So even in the inpatient side, primary care settings, skilled nursing facilities, home-based care, specialty care services like at cancer centers. So these are all opportunities really to find out what matters most and continue building that relationship. Examples, and these are real examples. So after discussing an increase of a core egg dose, this medication makes me exhausted. I am worried I'm going to be too weak to attend the family reunion I've been looking forward to next month. So here we have a capture into what's really important to this patient and why this increase in core egg dose may just not be a high priority for this patient and may be something that they're opposed to. A heart failure patient who is non-adherent on Lasix. You know, I've been attending both my grandson's baseball games and the bathroom's too far from the bleachers, so I just can't take it on those days. And this is a patient that was labeled as non-compliant, right? So they were just coming in, having, complaining of swollen legs, shortness of breath, and no, I don't take it, and this is why. But this was his priority, was his grandson's baseball game. 2 grandsons he had, and they had multiple baseball games. One was on a travel team with multiple games in a weekend, and the other one was on a little league team. This one was a truck driver. He's a type 2 diabetic on metformin, 1,000 milligrams BID, and he said his stomach was so upset and the loose stools are intolerable. But taking insulin just won't work for me. I'm a truck driver. I can't stop at regular intervals to eat or check my blood sugar. So several layers here, right? He's a truck driver. Eating regularly, at regular intervals doesn't work. That's a problem with his diabetes. Checking his blood sugar. But we also see here that there's a factual premise or misinformation that in his mind that it's metformin or insulin. He doesn't know that there are other options. There's an opportunity for education, but we also see that for him, obviously, his work and his, making a living is clearly a priority that we need to address with his medication and treatment plan. So what matters most, there are some clinician tools. The IHI Age-Friendly Health Systems Toolkit is a great one to read through if you're interested in implementing as a practice. This patient and caregiver tool, this is a conversation guide, so patients and caregivers can go through its health literacy appropriate and kind of talk about how to start the conversation with your provider about what your goal of care and your priorities are, what your goals are, what matters most to you in your life, what your hobbies are, what you want out of life. And so once we start this conversation, we also have to be willing and sometimes even advocate for our patients when there's a difference between caregiver priorities and patient priorities. So caring for older adults really involves a multitude of priorities, and what matters most is the top, but the current guidelines obviously we have to consider. We also have to think about multiple chronic conditions at once. And then social determinants of health. Is this even feasible for this patient at this time in what they have to face and what's going on in their life? And then after it's implemented, did the benefit outweigh the cost? Did it work for them outcome-wise, financially, social determinants of health-wise, and are they satisfied? Did it meet their goals for their health outcomes and priorities? So shared decision-making model, this is the model that I like to use personally with my patients to arrive at our treatment plan. This is a model that's a little bit different than MI, and we'll talk about the differences, but it's a communication skill focused on the patient's values and preferences. It's an effective patient care is the priority of the focus of shared decision-making, and it's collaborative in nature, meaning you're considering the dual expertise of both the provider but the patient as well. So they're considered both as experts. The patient's their own expert, but the provider's also an expert. Providing information is helpful, but it's not sufficient. In other words, our role, we can't just provide information about the chronic condition, we have to collaborate with the patient on the chronic condition. So this is a dynamic interplay between both provider guidance and the patient values. So the differences between MI and shared decision making, and MI is a great technique to use, but it is more one directional, and we'll kind of talk a little bit about the differences. But it's great to use when you're engaging patients in behavior change. So if you want them to engage in some type of behavior change, this is a great technique to use. But motivational interviewing is designed to enhance an uptake of maybe medical advice and improve an outcome. But shared decision making, given there are several options here, can you help me understand what's important to you in this matter? What's most important to you, what you value most? When we're talking about things like quitting smoking for behavior change, what would it take you, on a scale of 0 to 10, where are you at in quitting smoking? What would it take you to get you to a higher number? And then on shared decision making, what are your values and preferences? With motivational interviewing, it's more one directional, whereas shared decision making, there may be multiple options. Using shared decision making, patients have more accurate understanding of risks and benefits, and this is why it works. There's less decisional conflict because they're the ones involved in making the decision. And there's increased congruence with their own values. So they're more likely to adhere to the plan, and it continues to foster that trust that you do care about what matters most to them. And so that's why this model works. The HRQ have some steps to implement this model, and it's the SHARE acronym. So seek your patient's participation, help your patient explore and compare treatment options, assess your patient's values and preferences, reach a decision with your patient, and then evaluate your patient's decision. Some potential barriers, but also solutions to this in primary care. Obviously, the biggest barrier is time. And so we're faced with short visit appointments. We don't have a lot of time to spend conversing about all the options and trying to reach a decision together. And that's why utilizing a team is important. Sometimes we have to enlist the help of an interdisciplinary team. And we'll talk a little bit about more what that team can look like. But we may need to do appointments differently, right? We've started implementing telehealth. So telehealth visits and phone visits can be really helpful in this scenario. Creating space. So what I like to do for some of these visits is to do schedule these as follow-ups and really do kind of talk visits. And the aim for these visits is strictly goal setting, planning, education, and really self-care management support. So we've got, we're addressing your diabetes today. And today we're going to just talk about what our next steps are. Where are you at in your diabetes, and what are our treatment options? Kind of a snapshot. And it's really patient driven. So what are your priorities? What are your current concerns? Are you experiencing any side effects from the treatment plan you're currently on? What direction do we need to head in? And these are great for telehealth and phone visits. Another thing you can do is if you are at a point where you're trying to compromise with patients and you're trying to help them get to a certain goal or outcome with their chronic disease, and you may need to compromise, you can do a trial of care where you say, okay, this is what matters most to the patient. We're going to try to get them to this kind of goal. Let's do a trial period of this treatment. So how about you just try it for 30 days and we'll see how it works for you. And that way they're not thinking of it as a permanent change, but it's just a temporary change. Let's take 30 days. Let's take 2 months. Let's give me 2 months and you'll try this medication, and then let's readdress and see where we're at and find out how you're feeling on it and what your numbers look like, or and see if it's working out for your lifestyle. So these are kind of ways to compromise with the patient and gain to the rower. Again, I like to always approach it from that kind of role perspective, is these are your helpers, right? It's not my helpers. It's part of your team as the patient, and that's enlisting that interdisciplinary team. So at UCI we use pharmacists. We have this both at the UCI. We also have one at the Anaheim FQHC, and so they can actually make an appointment specifically with the pharmacist. We as providers can consult the pharmacist to help make decisions about treatment plans and options. We can utilize social workers or dietitians, as well as health coach. So here on campus at one of our sites, we have health coaches on site. And oftentimes after we've established kind of a treatment plan or had an appointment like this, our health coach will come in and offer support, or come in after the visit, or they'll make contact with the patient on a regular basis, and they'll come up with appointments, and they'll do those on telehealth visits or phone appointments. And they basically offer as a coach, kind of a health coach, but they'll do it with chronic diseases. They do it a lot with our diabetic patients. patients and just offer that additional support with regards to behavior changes and adopting the management plan. And then group medical visits are great. These are obviously reimbursable, and this is great for peer-to-peer support. So studies have shown that for self-care management, it's important for patients to also identify peers that are in the same situation and can also give them tips and identify as part of a community and a group. So group medical visits are great for helping patients empower themselves to manage their own diseases. And then other outpatient services, diabetic educators, heart failure coordinators, and then home health services. So especially after a transition of care, making sure that you've got social dietitians or specialty care services. So these are other options. Last but certainly not least, I'd like to talk a little bit about self-care. This is especially important in the face of the pandemic. I know that at UCI Health, even 2 of my own children's pediatricians have retired recently. They weren't planning on, but because of the pandemic and the stress that they have faced, both of them ended up retiring. So we've just had a lot of burden as providers, and so it's been challenging. And if we aren't addressing our own needs, we can't take care of our patients well. And so when I talk about self-care, there are 3, main principles. Number 1, it's not selfish. It takes intention, and also the principle of avoiding using coping mechanisms that aren't healthy. Working too much, working overtime. And when we talk about self-care, while bubble baths and chocolate is nice, it's also behavior and cultural, right? So there's a culture of self-care that you can implement as a practice. So if you get together with your office and your other providers and your faculty and staff and you say, listen, this is how we are going to implement, and setting boundaries, whether that's we're not going to answer our inboxes. As a group, let's set the boundary that we don't work through lunch. We don't chart through lunch. We don't answer our inboxes after a certain time at night. Our patients shouldn't have access to us 24/7. We need a work-life balance. Our patients need to understand that. If we adopt that culture as a team, then you're all doing the same thing and you understand it. Asking for help when you're struggling, right? Taking a step back and spending time, taking breaks when you need to during your shift. Leaving at 5 when your shift ends and staying instead of staying, being okay with letting the inbox stay if there's nothing pressing. And then just really making sure that you're saying no when you need to. When you make a mistake, forgiving yourself. So these also are really important aspects of self-care that I mean to discuss. The next thing to do, and this is really helpful in mitigating burnout, is being mindful and connected. And this is important because throughout the pandemic, we've been so stressed and so burnt out that mistakes can be made. And if we're not staying connected, if we're going patient to patient to patient, and our minds aren't present, errors will happen, mistakes will happen, and we won't be able to hear what matters most to our patient because we're not engaged and we're not connected to that visit. So I'm not talking about mindfulness on the weekend and meditation, and going into yoga and meditation. While those things are great, I'm talking about during your shift, getting into a habit of doing something quick and short that will help you stay connected and mindful and present. So this can look like several things. One that I like to use is abdominal breathing. And this is where you inhale for 4, hold for 7, and breathe out through 8. And this is, if you do this for 5 cycles, you're really starting to engage the parasympathetic nervous system. You're going to decrease your heart rate, decrease your respiratory rate, lower your blood pressure, and really get out of that fight or flight anxiety mode and get into more of a physiologically calm, peaceful, centered mode. Doing a 30-second mindful meditation where it's really great to do outdoors, where you do 3 cleansing breaths of the 4, 7, 8 cycle, and then you notice all 5 senses. What do I see? What do I smell? What do I hear? What do I taste and feel? And then a loving kindness meditation, and I love to do this for patients who are challenging. May I be happy, may I be well, may I be free from harm, and then may you be well. And I say this in my head before I walk into the exam room. May you be well, may you be happy, may you be free from harm. So these are great things to do just to kind of recenter, walk in fresh, kind of reconnect, wipe the slate clean, and and be mindful and present. And then a gratitude, which is 3 cleansing breaths, the 4, 7, 8. And then I'm grateful for having dinner tonight with a friend. I'm grateful for my kids being off on Monday and I get to connect with them. Something simple just to recenter and be grateful. So in conclusion, just remember that, remember the boat analogy, remember the roles that you have as a provider and patient. Empower your patients to row their own boat. It's never too late to promote health and wellness, even with multiple chronic conditions. Rather than react and have to throw them the life raft downstream, use the upstream approach in promoting health. The 4 M's must be considered in the face of any chronic disease, always keeping these in mind. Mind, mobility, medication, and what matters most. And then engage in shared decision making to really empower your patients to do their own self management within their chronic diseases and their health. And then create space for you. Make sure to engage in self-care and mindfulness so that you stay well and healthy and can take good care of your patients. These are some additional resources online that can help with kind of building and assisting and tools for your practice as well. And then I think we have a case that Dr. Lee and Kaligi were going to discuss. I'm going to stop share.
Hey, thank you so much, Dr. Campbell. That was such a wonderful presentation. We'll definitely be able to send the recording and the slides as well with the resources. I know you linked a lot of wonderful resources that they can refer back to. So I will be sure to send that out to everyone. And so thank you so much for that. And Dr. Lee, I know you have a wonderful case we wanted to kind of go over that is applicable to this session. So let me go ahead and share that case. And you can give us a quick overview of this patient.
Yeah, I'd love to. Thank you so much, Dr. Campbell. There's always so much to learn about chronic care management. So I have a really challenging patient case. So I wanted to ask for your help. So this is a lovely lady I met in Dr. Kaligi's clinic about a month ago. This is a 76-year-old female with past medical history of NIDDM with well-controlled A1C, hypertension that is poorly controlled, rheumatoid arthritis, right breast cancer history that is ERPR positive and HER2 negative, that was treated back in 2010 and status post right radical mastectomy and chemo. She also has a well-controlled asthma, fibromyalgia, as well as chronic back pain after back surgery requiring chronic opioid treatment, as well as osteopenia, as well as obesity with BMI of 42. So I'd like to share with you the medications that she's on. For hypertension, we were commenting on the very odd regimen for blood pressure. So lisinopril, hydrochlorothiazide, 20 milligram and 12.5 milligram combo. That is 3 tablets, as well as Corec 37.5 milligram BID, which we've noticed that this is such an elevated dose. And then we also have diabetes controlled on metformin, rheumatoid arthritis, for which she's on methotrexate weekly, as well as Plaquenil. Follows with rheumatologist. For her asthma, it's well controlled on Advair as well as Montelukast, has albuterol PRN. For hyperlipidemia, she has Lipitor 10 milligram, melatonin for insomnia, some bowel regimen, as well as hydrocodone 325, TID PRN, as well as morphine 50 milligram BID, as well as gabapentin 600 milligram at nighttime for her fibromyalgia pain, as well as low back pain. And if we can just go down a little bit farther down. Thank you. So I heard about this patient before the visit that, she has this really poorly controlled hypertension, and she tends to not really not able to really control it well. She's not checking her blood pressure at home. And also, she has not completed a 24-hour ambulatory blood pressure monitoring that had been ordered before. For her osteopenia, where she follows with a rheumatologist, she has not completed a DEXA scan that was ordered for her. Um, for her right breast cancer history, she followed up with her breast cancer surgeon many years ago, and she's not following up with them despite their recommendation. So just kind of looking at her, I'm just, I would be honest with you that I get these emotional reactions, and it's not a positive one. When we see our patients like this, how do you approach this?
That's a great question. I would I would look up. So go ahead and scan back up. I would I would approach this from a couple of things. I would certainly kind of I would definitely want to screen her for some depression, given that she has multiple chronic conditions, and it looks like she's probably experiencing a high level of pain. So I'd want to kind of find out what her overall her goals for care is. You know, what are her goals for life? What does she want to do that she's not doing? What is she, what does she want? Are there things that are bothering her? But I would certainly screen her for depression. This sounds like a patient, especially if she's got big emotional reactions, and if she's, she's obviously morbidly obese, and she's experiencing a lot of pain. Let's screen her for depression, and what are her overall goals for care? What does she want to be doing that she can't do currently? What's limiting her in life? So I'd really want to know from my perspective, what does she want? What's bothering her the most? Is it still uncontrolled pain? Is she does she have untreated depression? Looking at her fibromyalgia, I think you had mentioned up there that she has fibromyalgia and she's got pain. Should she maybe be on some Cymbalta that could maybe address both if she is depressed? So I would kind of start with there, and address. And I wouldn't feel obligated. This is a patient that you could look at and get really overwhelmed with, I think, right? Probably in your visits.
Yeah.
And I wouldn't try to, I would try to just address the most important thing one at a time. So what I do with my patients is I try to address what matters most to them first and establish the trust. Because if they find out that I'm willing to work with them and do what matters more to them, I care less about the BP monitoring. If they're looking, like, how's her blood pressure in the office when she comes?
So when I called her, I'm so glad that you asked that question. I asked her to please check her blood pressure at home using her blood pressure cuff.
Yeah.
And she actually dropped it during our visit, and she could not really pick it up. So that was what happened. So I called her, yes, but I called her a few weeks later and asked her, what was your goal? What is your goal? There are some of these things that are not addressed. So what do you hope to gain out of? And then at that moment, I don't know why, but she just, instead of answering my question, she said, I'm going to start having my caregiver check my blood pressure. And I don't know why, but we just clicked at that time.
Mm-hmm.
So I didn't really trust her that she would follow up with this. So I called her just yesterday in preparation for today's presentation. And she actually told me her blood pressure, most recent one, was 162 to 167 over 80. Not well controlled, but still it's a small success. So
Mm-hmm. Yeah. So I mean, I would just try to start developing that rapport and really gaining her trust first.
yeah.
To find out what her goals are and what's bothering her most. What does she want to be doing that she's not? And I would be concerned a lot about mobility and fall risk. She's morbidly obese. She's got big time pain meds on board and things that can cause her with the gabapentin and the melatonin. So with her fall risk, I'd be worried about that. And I'm happy to hear from Dr. Sagal or Dr. Gibbs. Any other thoughts?
I agree with you, Dr. Campbell. I think assessing her mood, certainly, and small, really capitalize on these small wins. And I would prioritize the patient-doctor or the patient-provider relationship over kind of the medical aspects of her care initially.
Exactly. Yeah.
And I like the fact that you've called her a couple different times to really check in on her and show her that in a very tangible way that you're interested in her care.
Yeah. And talk about things sometimes that aren't medical, that have nothing to do with medicine. Ask her about her life. Ask her about who she is and what's going on. I find that just connecting with patients, and that's where, just building that relationship and getting to know them really will maximize, because then she realizes you're not pushing, you don't have just an agenda to push. You really do care about her, and just listening to what she has to say and listening to her stories, getting to know her better without just always having to push a medical agenda will really go a long way.
And sometimes I'll ask patients like this what type of relationship they've had with their previous providers and what the relationship was like and what they liked about it and what they didn't like about it. And I think that can be very telling.
Yeah, that's a good point. Exactly. Great.
Thank you so much. Does anybody have any other questions for Dr. Lee about this patient or any suggestions for her? Okay, well, thank you so much. Dr. Lee, do you have any other questions for us?
No, I think that was wonderful. Thank you so much.
Thank you so much for sharing this patient case. If you ever have any follow-ups, we're happy to have you come back and give an update on this patient in one of our future echo sessions. So thank you so much. We do have some updates for you before we end the series. So we do have the CME forms. Please fill those out if you do want CE credits. We do take attendance at these sessions as well. And then we always appreciate your evaluations at the end of the sessions. We do have, this was our last session in this specific series for the UC Davis Primary Care Network, but we do have an upcoming series starting on March 4th on cognitive impairment. And our session topics are listed right here, if you can see that. Cognitive impairment, the basics, supporting family caregivers in primary care, the pharmaceutical treatment of dementia, weight loss in your patient with cognitive impairment, and then pre-death grief and dementia caregiving. So lots of really engaging topics, and we'll hope that you'll still join us for that next series, and those sessions will take place every 2 weeks. And again, it is CME accredited, so there will be free CMEs for your attendance there. I will be sure to send these slides out and the links to register. So be on the lookout for that email coming through. Wanted to thank you all for staying with us through this series, the last 4 sessions. So I hope you found them beneficial to you. If you have any questions along the way, don't hesitate to reach out to us, and we hope to see you at our next session on March 4th. Thank you all so much, and thank you to our Hub team for being a part of this series and helping make it so successful. Thank you.
Thank you.
Have a good day.